All right, today we're going to talk about a classic case of mistaken identity when it comes to bone disease. This is a diagnosis that gets missed a lot, and that can really change things for our patients. So let's dive right in. So picture this. You've got a patient who comes in with diffuse bone pain, and you get a scan back that shows low bone mass. Your brain immediately goes to osteoporosis, right? I mean, that's the classic textbook answer. But what if it's not? What if something else is hiding in plain sight, just pretending to be osteoporosis? This is where we, as clinicians, have to be super sharp.
Okay, so let's start by looking at the main suspect in our differential diagnosis.
So what exactly is osteomalacia? Well, at its core, it's a problem with bone quality, not bone quantity. Think of it like this. Your body is trying to build a brick wall. It lays down the scaffolding, that's the bone matrix. But because of a major, prolonged vitamin D deficiency, it doesn't have the cement, the minerals, to actually harden the bricks. So you end up with soft, weak bone.
And this, right here, is the big trap. A standard DEXA scan, our go-to for bone density, just measures how much mineral is there. It sees less mineral and spits out a report saying low bone mass. But it has no idea why the mineral is low. It can't tell the difference between bone that has been lost, like an osteoporosis, and bone that was never properly hardened to begin with. It's a huge blind spot.
So let's really dig into the fundamental difference between these two conditions. Because getting this right, well, it changes absolutely everything, from how you'll treat the patient to what you tell them about their future.
Let's go back to that brick wall analogy. Osteoporosis, that's a wall where you've started knocking out bricks. The structure is literally missing pieces, making it weak and porous. But with osteomalacia, you have a full wall. All the bricks are there, but they're made of soft, unfired clay. They just crumble under pressure. See? It's a totally different kind of structural problem. Okay, so how do we actually tell these two apart? This is where we put on our detective hats and start looking for clues. First, you've got to listen to the patient. Osteoporosis is usually silent, right? You don't know you have it until you break something. But osteomalacia, that hurts. Patients will tell you about this deep, achy pain all over. And here's a key clinical pearl. Pressed on their shin or their sternum. If they jump off the table, that's a huge red flag. Another thing to look for is proximal muscle weakness. You know that classic difficulty getting out of a chair? If you see those signs, your osteomalacia alarm bells should be ringing.
Now the lab work. This is where the story really becomes clear. In classic osteoporosis, labs are usually boring, totally normal. But with osteomalacia, you see this very specific pattern. The calcium and phosphorus are low or low normal, which makes sense because you need vitamin D to absorb them from your gut. And then the alkaline phosphatase, that's going to be high. That's a sign that your bones are screaming for help, trying desperately to build and mineralize but just not being able to.
And of course, the absolute smoking gun is the vitamin D level itself. And look, we're not talking about someone who's a little bit low, like a level of 25 or 28. For osteomalacia, we are talking profoundly low. The number you're really looking for is less than 10 nanograms per milliliter. When you see a number that low, you have to think about a serious mineralization problem.
And check this out, even the types of fractures are different. We all know the classic osteoporotic fractures, right? Hip, spine, wrist. But with the soft, pliable bones of osteomalacia, you get these really unusual stress fractures in weird places. Things like the ribs, the feet, or like you see here, in the heel bone. These are not your everyday fragility fractures, and they should definitely make you pause and think.
All right, so we've cracked the case, we've got our diagnosis. So what's next? How do we actually fix this mineral mystery and help the patient rebuild their bones?
The beautiful thing about treating osteomalacia is that it's so logical. You're not reaching for your typical osteoporosis meds like bisphosphonates. Those just slow down bone loss. Here, you have to fix the building problem. So step 1. Hit them with high-dose vitamin D. Step 2, make sure they're getting plenty of calcium and phosphorus, the actual building blocks. And then you just watch that alkaline phosphatase level. As the bones heal and mineralize properly, that number will slowly, satisfyingly come back down to normal.
And this is probably the most rewarding part of catching this diagnosis. Remember how we said the bone structure itself wasn't lost, just soft? Well, that means this whole thing is completely reversible. Once you give the body the tools it needs, that soft bone hardens up. And you'll see it on the follow-up DEXA scan. The bone density can dramatically increase, sometimes even back to normal. It's one of those rare situations in medicine where you can achieve a true cure.
One thing to keep in mind, though, is that you have to set expectations.
This problem developed over a long time, and it's not going to get better overnight. You have to tell your patient that the pain and weakness will get better, for sure, but it can take 6, 9, even 12 months for everything to get back to normal, so patience is absolutely key here.
So here's the bottom line. The next time you're faced with a patient who has low bone mass, I want you to just pause for a second. Before you write osteoporosis in the chart, ask yourself this one simple question. Is this a problem of quantity, or is it a problem of quality? Thinking about that distinction, looking for those clinical clues we talked about, that could lead you to uncover a totally reversible disease and, honestly, change a patient's life.